Today I'm joined by Professor Gemma Sharp, a clinical psychologist, acclaimed researcher and expert in the field of body image and eating disorders. Gemma is a leading voice in understanding how eating disorders uniquely affect women, particularly during midlife and menopause. During this transitional period, women experience hormonal changes similar to adolescence and going through puberty, which is another period of life where women are more likely to develop an eating disorder. In this episode, we discuss the complexities of eating disorders, early warning signs to look out for, and the neurological, genetic, or biological factors that can predispose someone to an eating disorder. It's difficult to know what to say or how to help someone struggling, and in this episode, Gemma shares some tips for approaching the subject in a supportive and loving way. Let's get into it. Gemma, thank you so much for coming on the podcast today. I really appreciate it. I would absolutely love it if you would tell our audience a little bit about who you are and your special interests.
So hi, my name's Gemma Sharp. I'm a professor and I'll soon be a professor at University of Queensland. So I was at Monash for a lot of years, but I'm very excited to be going up north. And my interest in body image and eating disorders started about over 10 years ago. I was actually trained as a lab scientist. So I was at the bench working with cell lines and pipettes and test tubes. It is the kind of cliche that people might imagine. But I actually started speaking with patients who were experiencing breast cancer and were having their breasts removed. And they were talking to me about their body image concerns. And I realized I really wanted to change fields and help more with, I suppose, a mental health perspective. And that's when I changed to clinical psychology, and the rest is kind of history. But I've loved body image and eating disorders for a long time.
Amazing. Okay. And so what I'd love you to do is explain what is an eating disorder and when does a problem become an eating disorder?
Yeah, and great question, because I think a lot of people may think they know what one is, but fundamentally it's a disturbance in feeding or eating patterns. So it's quite broad, and it can have impacts on our psychological well-being as well as our physical well-being, and unfortunately eating disorders are some of the most fatal psychiatric illnesses. So that's why we take it really, really seriously. And I think most people would have probably heard of anorexia and bulimia. They seem to be on television shows and in media a lot more often, but it's actually disorders like binge eating disorder and OSFED is what we call it, other specified feeding or eating disorder, that are actually the most common. And they are ones that don't really kind of fit into other criteria. So I think fundamentally just, a disruption in our connection with food and our bodies.
Tell us a little bit more about binge eating disorder and OSFED.
Thanks for the opportunity. I think they're very much forgotten, and binge eating disorder is kind of how it sounds. So a person will experience episodes of eating a lot of food in a short amount of time and feeling like it's out of control, like they couldn't stop it. So my patients will say things to me like, I felt like it was out of body, like it wasn't me who was doing the eating. So it's not just smashing out an Easter egg or something like that. It is a large amount of food in a short amount of time and feeling out of control, and doing this frequently such that it is a disorder. And OSFED kind of encompasses a few different types of eating disorders, but I think one that I'd really like to showcase is atypical anorexia. And people will say, well, how is it atypical? And so with anorexia, there's a certain BMI or weight criterion that people must be below the normal weight range. But we're seeing a lot more people come through now who've lost a significant amount of weight. And even after that, they're still in sort of a normal or above weight range. But physiologically and mentally, they look like someone who has anorexia and is low weight. So it shows really that it is that enormous weight loss and the disordered eating behaviours that is making them really, really unwell.
And do we know why people develop eating disorders?
$1 million question. And I mean, we know a lot more than we used to, but it's really a complex interplay of genetics, psychology, and environment, and also socialization. And it just seems to be that when this constellation comes together, that unfortunately some people will develop eating disorders, but I would like us to be looking more into the genetics and biological mechanisms, because I think then we'd be able to do better predictions of who will go on to develop an eating disorder. But we're still collecting that data. But I think it's still an area of growth, and I look forward to doing more in that space.
And if there are people listening who perhaps are concerned about, their teenagers or someone else in their family, is there anything that they can do to try and reduce the risk of someone having or developing an eating disorder?
Yeah, it's tricky. And I think having those conversations about healthy and regular eating and appreciating our bodies can certainly help. And we should be having those with our young people from a really young age. So we know that kids as young as 3 have a sense of body image, and they know the word fat, and they don't want to be fat. So we know that sense of their body and how that relates to themselves develops really, really young. And we often hear parents say that they never say anything negative to their child about their body, which is fantastic. But the way they speak about their own bodies is also really, really important. So if parents are saying, I hate my body, I want to go on a diet, about themselves, then the child internalizes that too. So I think if we have those healthy conversations about our own bodies and our children's bodies, then that can really, really help stave off an eating disorder.
And what else does the research tell us regarding like genetics and things like that?
Yeah, so I suppose we know the most about the genetic basis of anorexia nervosa. We're still looking at like bulimia nervosa, binge eating disorder, but the Eating Disorders Genomics Initiative is a worldwide initiative, and they're doing fantastic work. In terms of anorexia, it's super interesting. So anorexia actually the genetic profile looks like quite a lot of other mental health conditions, namely obsessive compulsive disorder. It also looks like schizophrenia. And also the way they metabolize fat is very different from the norm as well. So that's showing that they can actually maintain a low weight and still survive. So that's that genetic component. But also the obsessive component and the schizophrenia component absolutely fascinates me as well, because I think when we think schizophrenia, it's often people are thinking they are having delusions and hallucinations of things that don't exist. People seeing angels and devils and things like that other people can't see. But I think with anorexia, the delusion is focused on the body, and that's why they can't see their bodies like everyone else does. So I think there's a lot more to do there, but I think it's very interesting that it looks like other mental health conditions.
Yeah, gosh, that's so interesting. And so how prevalent are eating disorders in Australia?
Yeah, so we're very lucky that the Butterfly Foundation just published a report earlier this year, 2024, and we've increased to 1.1 million Australians with an eating disorder. So that is huge.
So that's 1 in 20?
Exactly. And that's full eating disorder, not disordered eating or other concerns. So there are a lot of people walking around experiencing an eating disorder.
If you could tell us a little bit about that Butterfly report, that would be amazing.
So the last time we had that report was actually 2012. So we've waited 12 years to get an update, but the suspense was great. Well done, Butterfly Foundation, on that. And we could see that there were definitely increases in prevalence of eating disorders in that time, particularly in the young people aged 10 to 19 age group. That was where one of the biggest increases occurred. And we also know it was a socioeconomic analysis. So I believe it was that eating disorders cost the Australian public $67 billion in 2023, $67 billion.
Wow. And so that's in treatment costs, but also lost work days.
Absolutely. Parents taking time off for their young person who's unwell, quality of life years lost. It was a very comprehensive analysis.
Wow.
Yeah.
And in terms of fatality, certainly at medical school, we always had it drummed into us of just how fatal things like anorexia nervosa are. And I think sometimes that's maybe a little bit lost in people. I think sometimes patients or parents or other extended family members think, oh, well, they just need to eat. And, why don't they just eat and they'll be fine? And it's very basic, and it's kind of, the reality is that, I've personally looked after a lot of people with eating disorders and had very young women having cardiac arrest and things like that.
Absolutely.
And so is the fatality around that physical deconditioning and heart concerns, or is there a connection with like suicidality, or is it a bit of both?
All of the above, as you were saying. So you can imagine that if you're living with anorexia, your quality of life is really bad usually. And so some people will become so despondent that they think there is no way to get better, and they will unfortunately complete suicide. But as you also said, heart failure is very common as well, because the heart muscle just wastes away, the electrolyte imbalance is there. It's just an incredibly devastating illness.
And in terms of, I can remember even as a, teenager, I lived in the UK, and we would see documentaries about various, people who'd set up like inpatient treatment in their own home. They would take these anorexic teenagers to live in their house, and there'd be like documentaries about that. And then there was
interesting.
And then there was like, it was all like moved into the hospital, and then it was moved back into the community. And so it's like the care has changed, keeping the young person at home and so where are we now with like what is considered the sort of gold standard of treatment?
Yeah. Can I say thank you so much for sharing that with me? How incredibly interesting. And I'm definitely going to look that up. And what a relevant question as well, because I have actually worked in, up until quite recently, in fact, a hospital in the home care model for eating disorders. So I think as much as we will continue inpatient care, that is absolutely necessary. There is also a push to be delivering care in the home as well, where the person is likely to feel a bit more comfortable, and we can go there and give meal support. Obviously, if they need medical stabilization, then that generally speaking, must be done in the hospital setting. But we're trying to do more care in the community as much as we can. I think there's not heaps and heaps of hospital in the home eating disorder programs around the world, but I think they will be coming through in the next few years more so.
And in terms of, like, have we actually progressed in the last 20 years to make this condition less fatal? Like, sounds like the numbers are going up, so it's becoming more, prevalent, but are we getting better at treating it, or does it remain that really, really difficult treatment?
Gosh, I think it's yes and no. I wish I had like a sort of clearer answer. I think we're definitely getting better at recognizing it, and early intervention is fantastic for eating disorders. We know that once they take hold and become long-standing, that they become much more difficult to treat. But as you said, more young people are being diagnosed at younger ages. In terms of treatment, we do have our gold standards, which is generally a multidisciplinary team involving general medicine, psychiatry, psychology, dietetics, social work, etc. And that seems to work quite well to support people, but I think we definitely need new treatments. There's no doubt about it. And in Australia, I believe we only have one medication approved for eating disorders, binge eating disorders specifically, and that's Vyvanse. And I think we can be doing a lot more from a pharmacological perspective as well to add that into the multidisciplinary mix.
The patients I've come across over the years, I have to say, I do feel like there's a lot of them. There's a lot of overlap with OCD as well. They often presented with a lot of obsessive compulsive symptoms. Are those two, as you said, genetically, they're probably connected? But would you say that's your experience as well?
100%. So it's very rare to have someone just with an eating disorder. Often they have comorbid anxiety, depression, OCD, sometimes a personality disorder in there as well. I suppose that makes treatment a little bit more tricky sometimes, but I suppose I love the challenge of that. That was one of the reasons I became involved in eating disorders. So I think it's about, I suppose it's person-centered care and whole person treatment whenever you're seeing someone experiencing eating issues.
Something I've experienced with my patient cohort is that my slightly older woman who has anorexia. It, in many of the cases, seems to also be partnered with alcohol misuse.
Yes. Yeah.
What's going on there?
Yeah. And it's called this ridiculous term like drunkorexia. And I think... And this certainly won't be everyone with anorexia, but I think it's tapping into a potentially more impulsive style of coping. I think some people will cope with food, some people will use substances, some people will use them together. It's maladaptive coping strategies coming along together.
Okay. And so then I know that both of us are very interested in the perimenopause and menopause. So tell me what's going on there, because we definitely seem to see a group of women presenting in this age group as well.
Yeah. And I wish I knew all the answers to that. And again, I think because we've unfortunately viewed eating disorders as a younger person's illness, we have neglected the research even more in that area. But the statistics show that it's about 3.5% of women in midlife, so age 40 to 60, are experiencing an eating disorder. So that's a significant amount of women. And what we have seen from the bit of research we know is that those estradiol and progesterone fluctuations, which make puberty a risk period, also seem to be playing a role in menopause transition.
Wow.
Yeah.
Okay. So it's not just a sort of a straightforward people in the perimenopause are putting on a bit of weight and maybe feeling discontent by what they look like.
I absolutely think that is playing a role too. And it's also a time of, it can be a time of identity reformation. It's like, well, who am I if I'm not in this reproductive phase anymore? And we know that women in midlife have lots of things going on, like busy time in their career. Maybe they're raising children. Maybe they're looking after parents. There's so much going on. And so it's hard to sort of disentangle those biological changes from those psychological and social changes as well. But I think it's quite interesting that puberty is also that identity formation period as well. So this is another time when women are really challenged.
Absolutely. I think one of the commonest phrases that people will say to me are two things. One, I don't feel like me anymore. And the second one is, I don't know who I am anymore.
Yes.
So I think that there's just that very fundamental identity crisis.
Yeah, exactly. And unfortunately, that's when eating disorders can really take a grip in the brain, where there is that self-identity questioning. And I suppose that's why treatment focuses a lot on that, generally speaking. But I completely appreciate women saying that they feel that way and what society is saying to them as well. It's a really challenging time.
And I know that you're very interested and have been for a long time in sort of like body dysmorphia and what people feel about their bodies. So what is it that society is saying to this group of women? Like, what is the subliminal message that we're all getting?
Yeah, I love to speak for society. I think as much as I hate to say it, women do tend to get valued for their appearance more than people of other genders. And that's really, really disappointing. And I think potentially what is happening is they're saying to women in midlife, you're aging out of your prime, potentially. Not that I agree with this. I just want to make that clear to your listeners, that maybe your best years are behind you. And it's absolutely no surprise that requests for cosmetic interventions are most common in that 35 to 50-year age group. Why wouldn't women want to say, I'm still acceptable, I'm still in my prime, I'm still worthy of your attention? It makes complete sense.
And in terms of this, still talking about this sort of midlife age group, are we seeing a different type of or subtype of eating disorder in this group?
Yeah, and the research is pretty limited, but what we do see, and I do think this is related to the estradiol and progesterone fluctuations, is more binge eating type presentations. You see, I suppose, a bit more restrictive type eating disorders in younger folk. Again, a lot more research to be done in that space, but certainly an increase in binge eating.
And in terms of using hormones then to treat this, is that very much a very important part of the treatment at this later stage?
I tell you, I would love us to, and I think we're sort of getting closer to that, sort of definitely having a plan for people who are experiencing eating disorders during the menopausal transition. And I think MHT, menopause hormone therapy, is a key part of that, particularly if women are having those menopausal symptoms. And we know that potentially if they've had an eating disorder before, they've been estrogen deprived as it is. So MHT could help them in a lot of different ways. And I absolutely recommend people reach out to their healthcare professionals to have these discussions.
And I want to talk about if there's a group of women who maybe had an eating disorder in their teens and 20s and then maybe, you know, have sort of stabilized and kind of lived with it. Because let's face it, I think a lot of people then get to a point where they kind of live with it.
Yes.
And it's sort of maybe a little bit just beneath the surface. Yeah. But is that group of women even more at risk than the average menopausal transition person?
$1 million question. Thank you so much for asking that. And we're not quite sure, but in the most recent research I've been doing, it was all women who'd had a previous eating disorder prior to menopause, and then it had reemerged. And I think potentially they might be more at risk. But that's not to say that I don't believe you can have new onset at the menopause transition. I think we're just not finding those women to be involved in our research.
For many years in my GP rooms and with friends and family, I heard the same story. People feeling overwhelmed with a huge array of skincare products on the market. Fears around having sensitive skin, choosing the wrong product, or being sold something they don't need. There are so many people intrigued by the latest trends and anti-aging treatments, but unsure if that would be relevant or actually even help them. And many are feeling afraid of being left looking different, silly, or even having an adverse reaction. As a doctor of 25 years, and of course as a woman experiencing the signs of aging myself, I am proud to have created You by Dr. Shauna Watts clinics. Led by myself and an experienced team of doctors, our goal is not to change you, just help you become the most confident version of you. Every journey at our clinic begins with a comprehensive assessment by our doctors and includes photography, skin analysis, a thorough exploration of your medical history, and of course, time to chat about your concerns and desires. Together, we create a completely customized plan, helping you achieve the confidence that you've always wanted. We treat all skin concerns, including redness, acne, pigmentation, sun damage, and all signs of aging. We take a holistic approach and only include evidence-based therapies. So if you're ready to start prioritizing you and exploring what we can do to help, please book in for a no-pressure Planning Your Aesthetic Journey appointment. You will leave with a full written plan and information on any recommendations. Our clinics are based at Foresters Beach and Newcastle, and you can book online at youbydrshaunawatts.com.au.
As a GP, because we've got lots of listeners who are lay people and we've got lots of listeners who are GPs and doctors and nurses and psychologists, like, what question should we be asking? Like, if I look at a lot of the questionnaires that we use for the perimenopause, and they're getting better and better, but some of them are, there's a lot of questions. It sounds like we potentially need to be asking a couple more that we're not asking always.
I think so. And I think in all of my assessments, and I should say as a psychologist, I have luxury of more time. So I completely appreciate the difficulties of primary care. But even if someone isn't coming to me for a body image or eating disorder issues, I will still ask about that sense of body image, sense of self, and also any changes in appetite or weight that they've noticed. I think these are fundamental questions that I would ask along with substance use, sleep, etc. I think they are just key questions that we should all be asking.
Okay. And if someone has a family member who they are suspicious is potentially, got a hidden eating disorder, do we know what the best thing to do is? Like, do we talk to them? I mean, I know I see a lot of parents and they, they're just desperate. They don't know what to do. Yes. I've seen lots of partners who are really distressed, and they kind of move between trying to be kind and supportive to literally being so frustrated and angry to probably guilting the person a bit into trying to put the pressure on to get them to eat. And, people move through this, I think, and it's very hard. It's very easy for us to say, be kind and compassionate.
Isn't it just?
When you're watching someone, probably shrink in front of your face and you're worried they're going to die. It's very hard to be really patient whenever you're freaking out, basically.
Absolutely.
But I'd love to know how do you approach the partner or the family, and what advice do you give to help with that?
I really appreciate what you said there about those different phases of frustration and fear, because I suppose we should normalize that first up, give compassion to the person who's worried, because they are right to be worried. They're using their spidey senses saying, hey, something's not going right here. And absolutely, they should be trusting their gut, pardon the pun. So unfortunately, there's a lot of denial in eating disorders, which makes it really, really tricky. And people will often think that their eating disorder is serving them well. It's helping them cope with a difficult phase of life. So you saying, hey, we want you to stop this eating disorder, you're kind of taking away their comfort blanket. They're like, no, this is helping me through life. So I think if we think about it more like that the person who's experiencing it might think this is actually really helpful. So we do need to, as much as possible, be kind, compassionate. Remember that they're not just an eating disorder, and talk to them more holistically. I would never go in with, I'm worried about what you're eating, not eating. I'm worried that you're hiding this. That is really direct and quite confrontational for someone experiencing an eating disorder. So keep treating them like a whole person. Say, I'm here for you. If there's anything you want to talk about, I'm always here for you. And absolutely keep trying to involve them in things like, I think there's sometimes a tendency going, well, they won't want to go to a restaurant. They won't want to go to that party. But if anything, you're isolating them more with their eating disorder. So keep trying to invite them to things. But as you also said, there will come a point where involuntary treatment is needed because the eating disorder has progressed too far. And that's very unfortunate when that occurs, but sometimes it's necessary and to medically stabilize people.
Okay. And about how often, what percentage of people have to happen?
Gosh, do you know what? I'm not sure. I need to look that up. Thank you for the question. I mean, we see it more often in young people because I think their parents and families are looking out. But sometimes we do have to have involuntary treatment for adults as well. It might be the partner or parents still. So yes, it's certainly not ideal because we know that the person really doesn't want to be there.
One of my experiences with eating disorders is there's often a lot of relapsing goes on, so we can make a lot of progress.
Yeah.
Often in a hospital admission setting, the person will often come out and, they'll have an appointment with me within the first week or so, and they'll seem really positive and everyone will be feeling really proud and everybody's very motivated. And, I can see that either things go really quite well for a while or actually within days to a week or so, we're back on an absolute roller coaster again.
Yes.
What's the thinking there? Is should you be quickly readmitted again to try and stop that real downward trajectory?
Yeah.
Or is it well, you can't spend your whole life in hospital?
Yes.
What is the kind of thinking around that?
And I think it very much depends on the person as well. But I think something I try to do in my treatment is always prepare for the end of it from the get-go. So the relapse prevention plan is drafted really, really early on because I think any transition point is tricky for someone experiencing an eating disorder anyway. So you can imagine going from hospital to home is a huge difference. And so it's not surprising that relapse occurs. So maybe, for example, that hospital in the home model where the care team are still coming out there, it's a nice little in-between that can help people transition to home more. So I think it's really kind of planning ahead a lot. And as we've also chatted about, people often are experiencing OCD as well. So, they're very particular, they're pedantic about certain things. So I think we need to sort of use that as a strength and go, okay, we're going to plan this as best we can for you. So you know exactly what it's going to look like as best as possible. And we execute that plan. And of course, as we all know, life doesn't go to plan and then maybe readmission then. Sometimes it's required.
Okay. And I suppose just because these conversations can feel a little depressing and negative, do you have good experience watching people, I suppose, get their happily ever after where they actually seem to fully recover from their eating disorder?
Absolutely. And I think sometimes we forget that that's actually the majority who go on to recover. And I always think about one of my earliest patients when I was a provisional psychologist, and good on her for getting better despite me. Honestly, I was so naive and fresh, but she also experienced substance abuse, and she just absolutely dug her heels in, gave everything to therapy, and she went on to have a brilliant life. And we were not too dissimilar in age, so I felt like we had a good bond. And it was just her absolute determination and guts to get better and go on and get married and have children. That was a huge goal for her. And that's always stuck with me. And I think I was very lucky to have that early in my clinical training.
Yeah, because that probably gave you a really positive one to always reflect back on.
Exactly. And like I said, despite me, she did well. I made so many mistakes. Good on her.
Whenever, we have people who are maybe themselves aware that they've got a problem, maybe no one around them has noticed. Maybe they're a mum and no one else pays attention to the shopping or the cooking, and no one's really paying attention to whether mum has any dinner because it's a busy household.
Yeah.
What would your advice be to that person in their first steps towards maybe asking for help?
Yeah, and I think as you described it, how difficult is that, like just to take that pause on life when there's so many demands going on there. But as you also said, they know something's not right within themselves. And that's really the first step, isn't it? Going, hey, I'm not feeling myself here. And maybe it is just that casual chat with the GP, just going, hey, I'm a bit worried. What are some options? Maybe she's not at a point where she can take them up fully yet because of all these other commitments. But there's really great online help in some instances where, she's probably up late at night with kids or something like that. Maybe she can engage with some of those things. And also something I really encourage people in the family unit to do is talk to some others in their family. Don't keep this just to yourself. That isolates you further. I know mums are really neglected and they do an amazing job, but I think if there's any opportunity to share with like a good friend, a partner, anyone like that, that can really be helpful too, having someone to talk to.
I think one of the things that I've noticed in that age group is there's a real embarrassment.
Sure.
I just feel really ashamed. They're putting their family under more pressure, or that they're causing a drama, and they feel so annoyed and frustrated at themselves. So it can be really tricky for them to actually admit because they just feel so humiliated.
Absolutely. And it shows how important those early conversations are with the friend, partner, GP, whoever, just to really validate the person and go, thank you for coming and asking for help. This is nothing to be ashamed of. And just really supporting them and supporting their decision to reach out for help, because they could have absolutely gone on another 5-10 years, maybe potentially got a lot worse and never asked for help.
In terms of social media, obviously, social media is here to stay.
Yes.
So there's no point in us saying otherwise. And the reality is that, we all enjoy it to some extent.
Me too.
What part do you think it is playing in the increased prevalence of eating disorders? Do you think that, all these people sort of influencing and showing a perfect life, or the use of filters on phones is giving people unrealistic sort of hopes and expectations?
Yeah.
Or the reality is that eating disorders have been with us long before that. So, do you think there is a contribution, and how much do you think it is?
$1 million question. Absolutely. And I think potentially I'm slightly controversial in my field in that if we didn't have social media to compare to, we were comparing to magazines, music clips, royal family. There's always been people to compare our bodies to. And as you said, eating disorders have always existed. I think what social media has done, it has maybe made us a little bit more appearance conscious because Our imagery is far more publicly available for other people's consumption and commentary. So our point of comparison has expanded, but the mechanisms of it remain the same. We have always been comparing ourselves to, I'm just thinking in the dim, dark past, the other people who lived in our caves, the people who lived in our villages. So it's just a very human mechanism to do that.
And whenever we talk about body dysmorphia, I work in both as a GP, but in that wellness and aesthetic space, and body dysmorphia has become really highlighted in that, like, for example, plastic surgeons and things are supposed to do screening now for it. So it seems to be a term that lots of people haven't heard of. And then sometimes other patients will kind of say it nearly kind of half jokingly. They'll say, oh, I think I'm a bit dysmorphic. And so it's one of those phrases that people throw out there. But Gemma, I know that's a real specialty of yours and special interest. What is body dysmorphia?
Yeah, and I really appreciate the question. And we've had kind of the term hijacked a bit. Like, people talk about Snapchat dysmorphia, TikTok dysmorphia. Like, it really is. Yes, it's become part of the vernacular, which I think is good. I'm glad that we've raised awareness, but I think, again, the sort of definition of it has been a little bit clouded. And I think people with body dysmorphic disorder, you absolutely know it, because their lives are really devastatingly impacted. So sometimes it will be that they can't leave their houses. I've even seen where people will not have dinner with their families because they're so concerned about this particular flaw that they're focused on. And that flaw can be their nose size, their hairline, their skin. It can be anywhere on the body. I've done quite a lot on genital dysmorphia. So it can be anywhere, and it can jump around as well. It doesn't necessarily stay in the same place, which is part of the fun of body dysmorphia, unfortunately. But what we do know from the research is that literally these people's visual processing is different from people who do not have it. So you have people with body image concerns, absolutely, but they may not have this visual processing deficit that people with BDD do. So when we look at eye tracking experiments with people with BDD, they jump around when they're looking at people's faces. So normally when people are looking at other people's faces, it's a triangle. They're looking at their eyes, nose, mouth. It forms a triangle. But when people with BDD look at faces, the tracking is all over the shop. And so we know that there's something going on with how they view themselves from a brain and eye perspective. And obviously there's a lot more research to be done there. But I think when people are sort of throwing the term around dysmorphia, they're probably not experiencing those visual processing issues.
And so, sorry, I know I'm slightly hijacking the conversation down that route, but so with body dysmorphia, what is the treatment?
Yeah, so generally speaking, it's cognitive behavioural therapy. It can be effective, but I suppose like the treatments for eating disorders, it doesn't always work.
Can I ask you to explain? People hear the term cognitive behavioural therapy all the time, but a lot of people don't really understand what that means. What is actually, so let's say specifically to body dysmorphia, what would you be doing in treatment sessions? What cognition would you be trying to change?
Yeah, and a really great question. And thank you for asking it, because I think us psychologists do just bandy CBT about far too often and not explain it. So particularly with CBT for body dysmorphic disorder, you're doing a lot of exposure exercises. So say, for example, someone who won't even go to their letterbox without a full face of makeup. This can and does happen. Or maybe they don't go anywhere without wearing a hat because they're worried about their hairline. So what you will do is you will help gradually expose them to these feared situations so that they become more and more comfortable with them. And in terms of the cognitions you're working on, so it might be, if I'm not wearing a hat, people will think I'm disgusting. Or if I'm not wearing a full face of makeup, people will find me unacceptable. They won't want to be near me. It will be quite extreme cognitions like that people will have, and you'll help them sort of chip away at them, reframing them. So you'll never get to the point of, if I'm not wearing makeup, I'll still be the most awesome person in the world. That's a bit too far-fetched, but it might be, I can go to the letterbox without wearing makeup and I'll be okay.
Thank you. That was really good, because I do think CBT is mentioned all the time and no one really understands what on earth it is.
I suppose the psychologists, we want to keep it mysterious so that we can still... No. I'm always happy to chat about CBT.
If we go back to eating disorders, sorry, that's my mind going all over the place. Do we have, should families be really encouraging that person to eat with the family, or should they be allowed to go and eat by themselves? Should family members be monitoring what they're eating, or just trusting that person to do it themselves? Where are we with that?
I think, gosh, and so individual as well. I think, and also dependent on the family. I mean, what if you've never eaten meals together and then suddenly you're eating meals together? It would probably seem quite strange to the person experiencing the eating disorder. But I think with family-based therapy, which is our go-to for generally young people experiencing eating disorders, you are kind of entrusting the feeding process with the parents, the caregivers. And so generally that is done as a family. You can get siblings involved as well. You don't want it to seem like a police station, though, where the person is being monitored to the nth degree. That no one would respond well to that, never mind someone with an eating disorder. But I think you're just trying to normalize eating again for this person, because that relationship with food has been really disrupted. But you will be sort of checking that the meal doesn't go on too long. Sometimes folks with eating disorders will drag out meals for hours. So you generally put a time limit on it, and you'll be very encouraging. You go, good job, next bite, you're doing really well. So it's not meant to be punitive at all. It's really meant to be just helping them form a better relationship with food again.
One of the things that I've noticed with families where there's someone with an eating disorder, there's a fear within the family that other people are going to catch it, as it were. And obviously I am saying that a little tongue in cheek.
Sure.
But people are really worried that,
Of course,
that the 17-year-old with the eating disorder is going to influence their 12-year-old as well.
Well,
is that a risk, or is that just a fear?
I think it's all of the above, really, because let's not deny the genetic predisposition. It runs in families. It's very rare to find someone with an eating disorder who doesn't have an aunt or a parent or a sibling who doesn't also have an eating disorder. So people are right to be cautious, but I think it doesn't need to be fear. I think it's okay, well, this young person, hopefully we can steer them on a different trajectory from our 17-year-old. Of course, I really feel for the 17-year-old, and hopefully they're getting the help too. But I think that early intervention is really crucial. And I will sometimes get parents coming saying exactly that. We're worried about little so-and-so who's 10. And so they'll get them into almost that preventative, really early intervention care with me to make sure that, or to at least try and avert a certain pathway.
And what about, I've got 4 children and one who wants to be a professional ballerina. And I have to say, amazing. But as a GP who I suppose has had more than their average number of eating disorder patients, it sort of at times strikes fear into my heart, because I feel like there are certain sports and performers that are seen to be more at risk of these things. Is that a reality, or is that just a perception?
That is a reality. I wish it wasn't, but it is, because I think in ballet, and I'm not a ballet dancer, so everything I've learned has been more through media, but obviously having clean lines, being athletic, you have to be, you're an incredible athlete to be a professional ballet dancer. So your body is your instrument. And I think, unfortunately, I hope this is changing a bit more. It seems to be, but certain coaching techniques, teaching techniques seem to really encourage disordered eating behaviours and body shaming young people because they didn't have the quote-unquote right body type for ballet.
We've seen it in gymnastics as well.
Gosh, yes. I think anything where there's sort of a weight class, or there's kind of a judgment based on the body's form, diving. I'm just thinking of all the martial arts where you have to meet certain weight classes. Just anything like that is more of a risk for eating disorders to come in. I think we are certainly giving more education to coaches, hopefully at all levels, to try and sort of not repeat some of the mistakes of the past. I'm just thinking, though, of a really cool YouTuber I've seen who is a professional ballet dancer, and I think she's promoting a really good message because she's saying, well, if I don't fuel my body enough, then I can't dance the way I want to dance. And I think if we keep encouraging food as fuel and your body as what allows you to do the sport or the dance that you love, then I think that's a very different perspective.
Yeah, that's right. Amazing. So in terms of, and if anyone's listening, do you have any sort of resources that you love, any websites, any apps, anything that you think that are really helpful?
Oh, thank you for the opportunity. And I will do some shameless self-promotion. I'm sorry about that. But I mean, I think obviously we're here in Victoria recording this episode, and Eating Disorders Victoria are a wonderful organisation, and we've recently developed our menopause and eating disorders course, which is freely available for health professionals and anyone else who wants it. So, and they also have pregnancy and young people courses as well. Butterfly Foundation, of course, as our national body. In terms of work that I've led as well, we have Gem, the chatbot. We recently launched it in North America as well, but it's an educational chatbot for parents, carers, as well as people aged 13 and up, and it teaches a bunch of micro skills. So if you just Google my name and Monash, you'll find it, but we also have it running in Canada as well. So if you click Canada and Gem chatbot, you'll also see our Canadian version. So I think there's a lot of great content there. And Inside Out, I know, have been doing a lot of work for GP education as well. So I think we're really lucky to be in Australia. We're very onto eating disorders. Obviously, there's a lot more work to be done, but I think we are very active in this space.
Yeah, amazing. And in terms of, as you say, we're based in Australia, we do have these eating disorder plans, which allow people to come to their GP. Yeah. We do quite a comprehensive assessment, and if you fulfill criteria, it kind of opens up access to not only more psychology sessions than you would normally get in your mental health care plan, and also to see a dietitian. And really, you're looking really for someone with a special interest, I think, in eating disorders. But yeah, I think there are lots of opportunities, maybe not so many opportunities for people who live rurally or remotely in Australia, which is a bit of a challenge.
Absolutely. And, I certainly do telehealth for that reason as well. And I think it's about having a really good relationship with the GP to make sure that on the ground care is being delivered as a coordinated team. But I agree, like, your postcode really does influence the care you get for an eating disorder, and it shouldn't be that way.
Just something you mentioned there piqued my interest. Eating disorders in pregnancy or eating disorders and postnatally, when you have those big hormone shifts and changes, do we have a propensity for more eating disorders then?
100%. Yeah. So it's sort of puberty, pregnancy, perimenopause, the 3 Ps. Any time where there is that hormonal shift, as you're saying, but also an identity shift, isn't there? I'm a new mum, or I'm now the mum of 2, 3, 4 children like yourself. That is a huge challenge. So it really is, unfortunately, another time where eating disorders can creep in.
Is the approach similar to what we've already talked about?
Yeah, absolutely. And I think, these folks are adults and they're caring for young ones, so it can sometimes be, I suppose, a bit trickier sometimes with treatment, but I think just that person-centered care, being there to support them, saying that you shouldn't be embarrassed or feel stigmatized because of this. You're like a lot of other women. That really can go a long way. I don't think, obviously we have our fancy CBT techniques, but sometimes it's just literally that supportive counselling that does a great deal.
Obviously, we've talked a lot today about really the multifactorial things that are all feeding into eating disorders. I think, again, one of the things I've noticed is often the mums of teenagers or children with eating disorders feel a huge amount of guilt. They feel like, oh gosh, it's me, I'm overweight, or I've always struggled with my weight, or I've always been on diets. But, probably they may well have had an eating disorder themselves, and we are in a bit of a cycle. But I think, as mums, we carry around big bags of guilt anyway for all sorts of things. And it just seems to be like another big burden on people.
I have never seen people beat themselves up more than parents. Like, it's incredible. I feel like it comes with the territory, doesn't it? And I feel such compassion for anyone who has been body shamed, weight stigmatized, because this is not within your control. If it was, life would be looking different. And I am so glad that we are actually investigating more why our weight fluctuates, why people are in those higher weight categories, and helping them more, because I think there's so much societal blame that people are subjected to because of their body size. Just, the classic eat less, move more. Oh my goodness gracious. It is not that simple. We are complex people and our weight is no different. And so I think we should absolutely take that no blame approach to parenting, as well as people's body size, because no one is choosing it.
I think for me, the whole conversation around Ozempic and Wegovy and the weight loss medications, I think really highlighted that, because if it was as simple as energy in and move more and be more motivated,
yes,
then actually something like Ozempic or the GLP-1 medications, they wouldn't have helped, because we wouldn't be injecting motivation. And
surprised they don't have that as a tagline.
And interestingly, people were always made to feel, if they were overweight or obese, that it was just their fault, and therefore if only they could be more motivated or more disciplined, yes, or more careful or whatever. But as I said, we didn't inject any of those things when we injected that chemical or hormone. And the reality is, I think, I would love people just to step back a little bit and go, this is much more complex than we think it is. And I think we also live in a society where actually eating constantly, overeating, ultra-processed foods designed to make you perpetually hungry, absolutely, actually probably more of the blame lays there.
Yeah, we live in an obesogenic environment. Like, gaining weight is almost a foregone conclusion. And I absolutely agree. I am thrilled to see the GLP-1 receptor agonists, and I look forward to more developments in that space, because people in larger bodies need the most compassion, not the least. They are possibly eating less than people in a smaller body. They have tried every diet. They know everything about calories probably. So this sort of thinking that they're silly or stupid and don't know what they're doing, that's just not true. They probably have more food knowledge than lots of other people combined.
Yeah, I agree. I have to say, I get on my soapbox, but it also makes me really cranky that currently in Australia, if you're having one of those medications for weight loss, you're paying about 3 times as much as you're paying if you have it for diabetes, and it is exactly the same medication. And I think it's just actually so discriminatory.
Oh, it is a class divide. It is the haves are able to access it and the have-nots are not. And that's not okay, because as far as my knowledge is, and all of my colleagues in the obesity space, these medications are lifesavers, game changers. I feel like they are one of the biggest innovations of our lifetimes, and they should be accessible for all.
Yeah, I agree 100%. So, Gemma, I have picked your brain inside and out. I'm sure I could pick it for hours more, but I would just love to finish, I suppose, with asking you if you have any tips that you would like to give to people who perhaps either they themselves or they have a friend or family member who they're worried maybe having an eating disorder.
Yeah, it's trust your gut, definitely. You're not imagining it. There probably is something going on, and it's great that you've picked up on it for this person, because they might not be aware of it themselves. Absolutely be there for them. Be that listening shoulder, because they might be feeling really, really isolated. Don't push them too hard as much as you would like to, but just say, if you ever want to talk about anything, I'll be here for you, because they will come eventually.
And in terms of still invite them to the restaurant, because they might just want to come.
Like, so even if they ate one mouthful, they're still at least socializing and they're not feeling as isolated.
Yeah. Okay. So I ask everyone who comes on the podcast a question, which is, if you could talk to 20-something Gemma,
Yes.
what would you tell her?
I love this question, and I really look forward to listening to what everyone else has said as well. And I think 20-something Gemma, she was sort of transitioning careers, and I think I remember thinking, oh gosh, I have to go back to university and keep studying. But I think I would tell her that careers and life are not linear, and it's actually those kind of twists and turns that are the most enriching. So, yeah, don't worry that it doesn't feel linear, because you'll get to where you want to go.
Well, you certainly have, with that professor in front of your name. Pretty impressive.
You. I'm absolutely thrilled to be in this position. And I wonder if I had stayed in my other field, maybe I might not be here today. So I'm very grateful to do what I love doing.
And you're moving away from the rain of Melbourne to the sun. Is it Queensland?
Yes. So University of Queensland have been amazing, and Brisbane is going to be very sunny. I don't know how I'm going to cope with the humidity. I'm never going to have straight hair again. But oh well.
Sacrifices to be made.
Exactly. So we'll be expanding our eating disorders and body image and body dysmorphia research even more. Clearly, appearance concerns might exist in Queensland. So I think we're going to have a rich environment to continue our research.
And if anyone would like to find you, how do they find you?
Yeah, absolutely. So I'm on LinkedIn. I'm on Twitter /X at Gemma Sharp 11. I'll still have my Monash account going, but I'll also have my University of Queensland account going. And I'm lucky enough to be the lead of our International Consortium for Research in Eating Disorders. So if you just Google core-ed.com.au, you'll find me that way as well.
Amazing.
Thank you.
Thank you so much.
When I started this podcast back in December 23, I knew that I was lucky enough to have amazing conversations with various health professionals across all facets of medicine and allied health. And I knew that you would probably really enjoy being a fly on the wall to hear what we talked about. And that's how the podcast was born. And what you probably don't know is that this is a bit of a passion project. We don't have any sponsors or funding. And without your help, we won't be able to continue bringing you these great guests. So if you can please spread the word about the podcast, share it with someone who you think might benefit from the conversation that you've just listened to, or if you can leave us a review or a comment, it would mean the absolute world, because that actually helps the podcast spread further and get more people to hear our message, and hopefully allow us to invite bigger and bigger guests onto the show. And I would so appreciate you helping me back. Thank you. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.